Good afternoon, everyone, from wherever you're joining us. It's my pleasure to welcome you to the 25th episode of Insights webinar series. This is a series hosted by eHealth Africa. The series brings together public health professionals to discuss critical issues and explore ways to enhance public health care delivery. My name is Moshood Isah. I'll be moderating this session today. So sit back, relax, call your friends, share the links with your friends, call your friends to join the conversation. Today is going to be a very interesting conversation. But to start like this, did you know that hypertension and diabetes are not just concerns for older adults, or they are not disease meant for older people as we perceive, because significantly young people are also impacted by hypertension and diabetes. Are you surprised? But then it's true. In Nigeria, approximately 30% of adults are affected by hypertension and diabetes, making these conditions among the most prevalent non-communicable diseases in the world. Unfortunately, access to quality and affordable health care for these conditions remain a significant issue. Of course, there's a lot to explore today. Importantly, our panelists today are experts in community medicine, and they have implemented innovative interventions to address hypertension and diabetes, of course, in Nigerian communities. Again, sit back, relax, invite your friends to join this conversation, a critical conversation on hypertension and diabetes. To introduce our panelists in no particular order, I'll start with Dr. Ronke Akonde. Dr. Aderonke Akonde, she's a consultant physician and a public health community medicine expert. She's a seasoned public health physician, a consultant and community medicine expert with extensive experience in disease control, epidemiology, and reproductive health. She's also a fellow of National Postgraduate Medicine College of Nigeria. She currently serves as a director disease control with the Federal Capital Territory Primary Health Care Board, Abuja. Dr. Akonde is skilled in policy development, research, health economics, and has made notable contributions to Nigeria polio eradication efforts. Dr. Akonde, can you say hi to our audience?
Hi.
Thank you once again for finding time to join us. Our next panelist, Dr. Nura, is the coordinator of the Non-Communicable Disease in State's Ministry of Health, Kano State. Before now, he had also coordinated HIV programs in Kano State successfully, and he's also the sector-wide approach desk officer in Kano State. Dr. Nura, thanks for joining us.
Hi, good afternoon, everyone.
Thank you very much for joining us. And of course, last but not the least, Lucy Okoye is a program manager for laboratory systems and diagnostics at eHealth Africa. She also led an intervention to tackle non-communicable disease in a project titled Digitization for Impact, Improving Access to Integrated Services for NCDs in Nigeria. Lucy has over 20 years experience. She's a dedicated public health professional and a development expert. She's a medical laboratory professional, a chemical pathologist specializing in laboratory systems, strengthening, public health improvement, and program management. Of course, prior to her role at eHealth Africa, she has worked with FHI 360, National Center for Disease Control, National Reference Laboratory, and many more. She has worked in intervention both in Nigeria and the African continents. Dr. Lucy, welcome to the 25th episode of Insight Webinar. Can you say hi to our audience?
Thanks, Moshood. Hello, everyone. Thanks for joining us.
Again, we have a lot to unpack today about hypertension and diabetes. But before we dive into this conversation, we have a short video on an intervention led by eHealth Africa in partnership with the EHA Rich Clinic. The intervention was able to address hypertension and diabetes in communities in Kano and Abuja. So we'll be playing this short video and sit back and enjoy. Thank you very much.
Diabetes and hypertension are complex diseases that require lifelong management. Many patients struggle with medication adherence, lifestyle challenges, and the emotional toll of living with this health challenge. According to WHO, about 422 million people worldwide have diabetes, the majority living in low and middle income countries, and 1.5 million deaths are directly attributed to diabetes each year, while an estimated 1.28 billion adults aged 30 to 79 years worldwide have hypertension, most, approximately 2/3, living in low and middle income countries. In this documentary, we explore a transformative project designed to make a real difference in the lives of those living with these conditions.
Diane is digitizing for impact, improving access to intermediate services or for NCD in Nigeria. It was EHA's board idea to promote innovation and creativity around solving public health problems. The overall goal of the project is to increase access to the treatment, the services of non-communicable diseases. People getting to be screened and then being enrolled and treated for NCDs. And then our focus on this project is hypertension and diabetes, which also mirrors how PEN was piloted, in Nigeria.
PEN intervention is very unique. It's like a metamorphosis type or an hybrid of WHO PEN. WHO PEN means World Health Organization Packaged Essential Non-Communicable Diseases Intervention. But Nigerian PEN narrowed it down. So we now use only hypertension and diabetes under NPEN because primary health care has been identified as the most viable ways of reducing the burdens of NCDs, particularly the cardiovascular diseases.
Non-communicable disease is the leading cause of death, not just in Nigeria, but globally. So those numbers are what inspired my team to scout more into what problem, what solution, how do we solve this public health problem. So that's how we came about the Diane project. One of WHO's reports, he said that if more people get to know their status, know their numbers in terms of hypertension, diabetes, and on all the NCDs, over 76 million deaths will be averted. So we thought to contribute to that, make people get to know their numbers, check people's blood pressure, blood glucose, and then, be able to know where they are and then take care of themselves to avert, these deaths.
Before now, I have a minimal knowledge of hypertensive and diabetic and these NCD issues, disease condition. But with the coming of this intervention, I have been trained for the knowledge of hypertensive, in and out of it, the complication, the signs and symptoms, and and even the drugs, side effects or the adverse effects. I'm perfectly equipped.
We acquire so many knowledge that we are able to put them, that is this key in practice, that's like checking of BP and also knowing the complication with all of this and how to communicate with our patient, like giving that rapport before approaching patients. So after the training and the initiation of this NCD, it goes a long way because there was more confidence in the both side, both the health, like we and the patients.
The current challenges faced by patients with diabetes and hypertension in this particular project is adherence to medications. We've had a few patients where we would have to keep following up counseling and, encouraging them to take their medications. Also,
Okay, thank you very much. The full version of that video is on YouTube channel, eHealth Africa. I had a lot of beneficiaries speaking on how they actually benefited from this intervention, where they were where we made an effort to actually tackle non-communicable disease. And to dive into this conversation straight away, first, before we dive in, we think we need to demystify this belief or this idea that, oh, hypertension and diabetes is for old people. Actually, young people are actually impacted. How do we demystify this? Why should young people be concerned about hypertension and diabetes? To start with, I want to start with Lucy. Why do you think young people should be concerned about hypertension and diabetes, and what actually inspired the need to empower rural communities with this kind of solution? Lucy, over to you.
Okay, thank you very much, Moshood. And then talking about how we can demystify, or that wrong belief that NCDs are for the elderly. So first is for us to know that the causes of this, be it hypertension, be it diabetes, we have some what we call modifiable risk factors. So that is why we should not, base it on just for elderly. So even the young people are exposed to it. And then, of course, we have a lot of young people come down with hypertension and even diabetes. So that is why on this course, I'm sure we're going to have some time to speak, to the NCDs, how people get exposed, or what are those risk factors. We have the modifiable risk factors, and as well as the non-modifiable risk factors. The people's lifestyle. You can see a young person who is an alcoholic. You can see a young person who is obese. Those are risk factors that exposes the young. So it is not just for the elderly. Everybody is involved. So having said that, to respond to your question again on what's inspired the intervention, again, it is absolutely not new that non-communicable diseases is the #1 killer. It has a lot of numbers in terms of deaths attributed to non-communicable diseases, right? So now we're talking about numbers and not numbers of lives that are being lost, deaths. So NCDs, from the WHO report, a recent report last year, 2023, it said that 41 million deaths are due to non-communicable diseases. And then out of these numbers, we have like 70% of them in the low and medium income countries. And then Nigeria is one of them. So this is it. People die every year. And then again, WHO also proposed in terms of intervention, their recommendation that if people get to know their number, if you can scale up the services, screening in particular, right? These like 76 million deaths will be averted between 2023 and 2030. So we're looking at lives and not money, we're talking about human lives. So how can we just, avert these deaths? And that is what inspired this, when the EHA board gave us this approval to implement the Diane project, is because it's going to make impacts. And especially with our approach, the approach is, is community-based. We're taking these services to the community. We're reaching them through outreaches, and we're going to their homes, and then we identify the treatment partners for those cases who are enrolled, who now support these clients. So yeah, so just to give that background, it's not about the number and how we can, support to, improve people's life. Thank you.
Interesting. And those figures are not just numbers. They are children losing their parents, they are parents losing their children, there are communities being vulnerable. So it's not just numbers, there are people being rendered with health situations. So they are not just numbers. But thank you very much for providing that background. Dr. Nura, you've coordinated HIV programs. You're also coordinating, non-communicable disease intervention in Kano. What do you think, what was the morale, or what is the inspiration behind putting this kind of intervention especially in Kano State, giving it as a context?
Okay, thank you, Moshood. Actually, generally there is a paucity of information concerning non-communicable disease across the urban and rural areas. Therefore, people are not aware of this non-communicable disease, particularly the hypertension and diabetes. Before they even come aware of it, they already develop some complications. Therefore, it's important to have information for anything before you know its effects or how it affects you. your family, and your society in general. And another thing is that there are underserved communities, particularly in hard-to-reach areas. Therefore, they don't really have access to good health facility. And even if the health facility is available, the experienced human resources for health are not really there. Therefore, they may not be having access to good health services. Apart from that, there is also a complication as a result of this non-communicable disease, which is dwelling the secondary and tertiary facilities. Therefore, people need to know about this complication. Before this complication set on, they have to kind of know how to prevent those complications. Actually, what we do in Kano, particularly in hypertension and diabetes, we do several things. Particularly, I would like to mention that in PHC facilities, this is where community are mostly accessible to. We do go to any patient or any client, even if you maybe accompany your relatives to the facility, you are going to screen for either hypertension or diabetes at the entrance of that particular facility. And another thing that we do in order to, reach out to this underserved community in rural areas is to carry out an outreaches for hypertension and diabetes, so that anybody that is found hypertensive or diabetic will be referred to a nearby health facility for further evaluation and possible medication. Thank you, and over.
Okay, thank you very much. Something I pick out in your conversation is about lack of information. You need to even have information about what's worrying you before you know the action to take. And even after having that information, you need the right expertise to diagnose issues that is bothering you. And even after diagnosing, you actually need the right facilities and equipment to actually tackle this kind of intervention. And this takes us to Dr. Ronke. I know there are regular ways, there are traditional or conventional ways of tackling non-communicable diseases. And of course, there are also innovative ways of tackling non-communicable diseases. I would like you to walk us through briefly. I know if we're given the whole time, you can take the whole day to discuss, but then briefly, how can you walk us through the most innovative way of actually tackling non-communicable diseases? Probably there are some new innovative ways from probably the World Health Organization, or the most innovative way of, or do you think we can tackle non-communicable disease, especially hypertension and diabetes?
Yes, thank you very much, Moshood, for that question. As we all know, hypertension, diabetes, cancers, sickle cell, and so on and so forth, they are all non-communicable diseases, which is the leading cause of death globally and even in Nigeria. So it is against this backdrop that WHO, the World Health Organization, in the year 2017, came up with a specialized package called WUPEN. WUPEN means WHO Packaged Essential Non-Communicable Diseases Intervention. So this is an innovative way of approaching community-driven intervention by which you utilize primary health care centers or facility as a means of providing services for non-communicable diseases. And it's just as if WHO has already cited what was ahead of us in 2017. We are now in the era of JAPA syndrome. Healthcare professionals that are supposed to take care of hypertension, diabetes, and so on and so forth, are a sizable number in the country. Not only in Nigeria, this is a global phenomenon. And a whole lot of countries, both developing and non-developing countries, are battling with human resource for health gap, in which we have a lot of doctors and nurses out of the system. So what WHO did was to package a few of these non-communicable diseases and presented this like a cocktail of intervention utilizing primary health care centers to deliver the cocktail. What do we mean by this? Primary health care workers who are community health officers, community health extension workers were trained under what we call tax shifting and tax sharing, so as to cover up for human resource for health gap in the health system. So what they did was to attend to cases that are uncomplicated and treat them within their purview of the protocols that are given to them. And those that are complicated are being referred to higher levels of health system, like secondary and tertiary facility.
Okay.
As we proceed on, we discover that there's a lack, there's paucity of funds to carrying almost 5 NCDs together and attending to them using this particular intervention. So Nigeria now modified it into what we called NPEN. That's Nigerian Packaged Essential Non-Communicable Diseases Intervention. It becomes our own. We domesticated it and just took a few. And a few that we took include hypertension and diabetes. And FCT, the Federal Capital Territory of Nigeria, was the only state where this intervention was piloted. And basically, the goal is that uncomplicated hypertensions are being treated at primary healthcare level. People have increased access to screening for hypertension. There was linkage to treatment of those that are positive, and those that are without elevated blood pressure also visit regularly to access these screening services within the localities where they live. And of course, that is the basis upon which primary health care is built on. That is the principle, taking health to the doorstep of the people. So basically, that is what NPEN all entails. So capacity building at lower cadre level of healthcare workforce has been able to improve access to screening. One thing about hypertension is that it is a silent killer. A lot of people don't know, but nowadays it kills publicly. You just hear slump and die. And commonly among young people, the youth, it's no more only about the elderly. In those days, we used to think, okay, hypertension, diabetes, they are all diseases of old age. No, the trend is changing. So access to screening is what NPEN is able to achieve, and in what form? In accessible manner, affordable manner, and in an essential way. You know, primary health care is all about taking health to the doorstep of the people, closer to where the people live, where they work, or where they earn their living. So this is what NPEN is all about. Thank you, and over.
Okay. Before I introduce her, I said she could take the whole day, and you can see how comprehensive this is. It is just for you to give us certificate of attendance for attending your TED Talk. But again, thank you very much. It's quite a comprehensive feedback you've given us, but a whole lot to actually unpack. from this. Again, if you have questions or comments, kindly use the Q&A chat box to drop your questions, comments. We have experts here. As much as we can, we'll take as much question as possible. Thank you very much again for this comprehensive feedback, Dr. Akande. Dr. Nura, can you context specific now in Kano? Are there specific tools or innovative ways feeding into this NPEN? What are the specific activities that fed into this NPEN that you implemented in Kano, especially while supporting this intervention?
Okay, thank you once again, Moshood. Actually, in Kano, Kano is one of the states, I think, that the NPEN was piloted by the program. Actually, there's community outreach. The community outreach that as I said earlier, most of the people not really have access to this screening of hypertension and diabetes. So the extension healthcare workers go to the community and carry out an outreach. After the outreach, if there's anybody that's fine with either hypertension or diabetes, it will refer to a clinic, that is Rich Clinic. That particular Rich Clinic, there's a medical officer there to be, place that particular client on medication. And if there's any complication or if the patient is not responding to treatment, that medical officer will refer to a specialist in Muhammad Abdullahi Wasi Teaching Hospital, where it will be, see as appropriate. And as part of the innovation in the states, we did, apart from the NPEN, we also create awareness to sensitize civil servants. Most of the civil servants do go to work from morning to evening, and it's the era of fast food. People are eating unhealthy food. Therefore, these NCDs are also related to this unhealthy diet. Therefore, we do sensitization for civil servants, that is periodically, and also we carry out periodic outreach to even the people that are within the urban area. Apart from that, they say that we should catch them early. We talk about these NCDs appearing in the young people now, because you may be seeing young people, there's what we call stroke, for example. One of the complications of either hypertension or diabetes is stroke. You see a very young chap with either stroke, we call it stroke in young. Therefore, we do go to tertiary institution across the states to give them sensitization lecture on hypertension, diabetes, and other NCDs, not even hypertension and diabetic only, but also cancer, sickle cell disease, and also the effect of smoking, because smoking is one of the risk factors for these non-communicable diseases. And apart from that, we do carry out periodic program on this NCD. For example, for week 1, we can take hypertension and we can get an expert on that and to discuss about his signs and symptoms, complication, and how to prevent those complications. So these are some of the innovations that we do in Kano to see that we tackle the menace of NCDs. Thank you, and over.
Thank you very much. Like we said, information is key. And then the right people should have access to the information. There are community influencers, community leaders that you need their buy-in to actually, implement intervention like this. Lucy, you led an intervention in eHealth Africa that aims to tackle non-communicable disease in rural communities. And you said it's digitization of impact. How did you manage to digitize this intervention? And how did you manage to feed into this NPEN to digitize this intervention and to reach out to communities?
Okay, thank you. Thank you very much, Moshood. So talking about digitization, like Dr. Akande said, Nigeria adapted to have Nigerian pen. So when we started intervention, when we did a lot of engagement with stakeholders, WHO, FCT, and Ministry of Health, the national program. And so we heard about the NPEN, and then what we did, they already have these tools, in hard copy. So what we now did was, of course, that's our strength. We have to put it in digital form so that it's easy, when the tools go out, they can actually easily use their tab, and then key in all those data from the screening register and all the tools, both the enrollment register and then even the inventory management. So we have these experts in house that the GHI team that supported that process. So now we have the NPEN, in digitalized form. So that's basically what we did on that. And then of course, we able to use it during the process or when we implemented the DIAN project, give it a try. And of course, there's still work in progress for us to, improve on that. Thank you.
Okay. Thank you very much. They say data is the new oil. Data is key. So data can impact on the kind of decision you're making. So moving from the paper form of documentation to having your data where it is reliably saved and accurate, which Dr. Lucy has said it was actually key in helping them implement this intervention. While she was talking, she mentioned something like CHOOSE. I know in the health sector, we like using abbreviation. CHOOSE is actually community health extension workers. So these are the people that were deployed using this for this intervention. Dr. Akonde, during the video, we saw one of the CHOOSE, one of the community health extension workers, mentioning that they were trained on using this digitized form and actually reaching out to patients. And I know we learned this training of this intervention. What has been your experience supporting this whole process? In brief, thank you.
Okay, thank you very much. My experience with DIAN and Rich clinic training on NPEN was actually a unique one. That will be the first time we experienced digitalization of NPEN intervention, actually. So we commend eHealth Africa for that. So starting from the training period, what I saw in the field was highly zealous and, the enthusiasm in the healthcare workers in this clinic are very encouraging. When I met them, they were ready to learn. So a few of interactions we had with them was to find out what would be their expectations at the beginning of the training. And when we compiled these expectations, I was marveled. So at the end of it all, when we asked them, they were also able to get more than what they requested for following the training, because the training was a very comprehensive one involving a team of cardiologists, seasoned public health physicians, pharmacists. Everybody came together to make a comprehensive, training package available for them, and they were able to grab everything in totality, to the extent that some of them were like, when do we start? When are we going to start? So they were very zealous and ready to work. And beyond this, I also learned a whole lot during the supportive supervisory visit to DIAN Clinic and DIAN Project and Reach Clinic staff. When we got to the clinic, the organization, the flow, the data management, everything was in order and was highly impressive. So later we proceeded to follow-up visit to a client. That was the peak of it all. It was like a family gathering, the way we were welcomed and the way we found out that even with this project, you can reach people within the household level, and you could see the kind of support the clients are getting from their family members, to the extent that there was a particular client that the son was like, okay, I'm interested. He knew everything, practically everything about the mother's treatment. That was a take home for me from this special project. And it was really highly impressive. Thank you.
All right, interesting. Whenever you implement an intervention, what do you want to see? Is real life, impact, where the beneficiaries are speaking on how this project has impacted on them, and storytelling, which actually can impact on other intervention. Again, thank you very much, Dr. Akonde, for that intervention. Thank you very much. Again, I know what has been the success stories of this, Lucy. You've reached out to communities in Kuje, I guess, in Abuja, in Gedi, in Kano, and some other communities. What is your biggest success in this intervention, especially reaching out to rural communities? What can you see as success? Meanwhile, I'm seeing your questions on the chat box. Please keep them coming. We have time to take them. What can you see? What can you define as success when putting out intervention like this? Can you share some success stories? Thank you, Lucy.
Okay. Thank you so much, Moshood, and then thank you, Dr. Konde, for that feedback. So talking about the success, I want to remind us that, we're health workers, and our efforts is actually contributing to achieving the Sustainable Development Goal number 3, which is good health and well-being. And then success for me on this project is the fact that, we are contributing to averting complications or deaths that would have increased the number that you saw, number of morbidity and mortality attributed to NCD. So first is the health promotion. I mentioned to you that, which is prevention. I mentioned to you that we do engage in outreaches. So when we do these outreaches, we speak about NCD. We talk about, give like a general information section, on non-communicable diseases and what it is, how you identify it, people that the modifiable risk factors, and and all that information that is being given. So this kind of make people to know that, because like Dr. Kande said, people don't get to know, and that's the record from WHO, one of the reports again, that like 4 to 5 out of people who are who have hypertension do not even know. They don't even know. So if you are not screened, you will not even get to know. And that's why most times people don't, until maybe when they drop and die, or when they have complications, that's why these things are identified. So first for me, the success story was, one, contributing to that, achieving that good health and well-being, which is the health promotion component of this project, where we reach people with messaging, right? Secondly is the impact. Like she rightly mentioned, people who ordinarily by now, because we've implemented this project for like 8 months now, by now, these numbers wouldn't have known, like close to 500 people that were screened or more, wouldn't have even known that they had, they were hypertensive or diabetic. So, but this project has actually helped us to identify that. And then of course, people are placed on treatment on the project. It was a free treatment. And then this also averted deaths, because of course, when people come down with complications, what happened? Results to death, ultimately. Then the third is the impact we have on I'm sure people are going to go to our website to watch the video, the documentary, because these CHUs that are trained, it's a lot for you to have people who are competent to be able to provide the services. So this project was able to accomplish that. We empowered the CHUs, they were well trained, we got the experts in the house, the trainers, and to support this training. And then they are empowered, and that is why we have, the results that is being recorded, because when they go out to the field again with our own intervention, our approach, so they are empowered, they give quality counseling, quality services, they engage with these patients, with the knowledge that they need to know, and they pass this knowledge, and that's why most of our patients were able to adhere, to the treatments. So these are things that, gladden my heart that we have a lot of success story, beyond the fact that, EHA is able to demonstrate our capacity to be able to implement, non-communicable diseases in Nigeria, and listed. For instance, in Kano, the director was very happy with our project. The fact that we came down to Kano, like Dr. Gane said, it was only piloted in FCT, but eHealth Africa is able to pilot that now in Kano. So these are things that, gives us joy that as health workers, our sole aim is to save life. And I see these projects impacting life, getting to the grassroots and then making the difference. Thank you very much, Moshood.
All right, thank you very much. Dr. Nura, do you want to add one or two things to this, especially from Kano? I know you did stakeholder engagement, you reached out to communities. Are you getting positive feedback from those communities, especially around success when it comes to reaching out to your communities with this kind of intervention? Do you want to add one or two things?
Okay, thank you, Moshood. Maybe I will look at it in three ways, the impact of this project. First, you see, it creates more awareness, particularly in that particular community on hypertension and diabetes, therefore prevent complication. I can remember when we went to visit the Rich Clinic, we saw a lot of young people being attended by the clinician at that particular clinic. And another interesting thing that I want to highlight here is that the healthcare workers that were trained now is kind of sustainable projects. Even if there is no eHealth, those healthcare workers have already developed that capacity of addressing hypertension and diabetics, and at least they know their limits, when to refer and not when to refer. I think these are the major things that I want to add on this. Thank you, and over.
Yeah, thank you very much. Knowledge is key. If you impart knowledge, it means you impart someone with knowledge. There's tendency that you're impacting the whole community with knowledge. But again, it's not all rosy. It's not all rosy out there. These experts, community health extension workers, project managers face a lot of challenges while implementing this kind of intervention, and we learn from this, and then so that in the future we know how to tackle this kind of challenges. Dr. Winke, again, let me come back to you. In summary, what are the challenges you face when reaching out to communities with innovative solutions for non-communicable diseases?
Okay, thank you, Moshood. Talking about challenges, NCDs are long lasting form of disease that are related to lifestyle, environmental factors, and probably exposure to some social vices like intake of alcohol, smoking, tobaccos, and so on and so forth. So that tells us that combating the menace of NCD requires a multi-sectoral and multidisciplinary approach and should be everybody's business. Considering NCD as the leading cause of DALY, that's disability adjusted life years of the people, is among the leading in the global disability scale. So now, we, in our own little ways, and eHealth in their little ways, are making impacts, to reach out to the people who are apparently healthy until they get screened and get to know that they are not actually healthy. Improving access to screening. However, paucity of funds is still an issue. This is just a small project, touching just a drop from the ocean. A whole lot of people at risk are still out there that we have not reached. How I wish we can have the HAM project and Rich Clinic in every ward of the Federation, every local government, every state. It would have gone a long way, reducing the burden of NCD. Another factor is that of lack of awareness. A lot of people are not even aware that they need to change their lifestyles in terms of what they eat and the access to different kind of food within the market. People don't have informed, you know, that they don't have enough information that can make them to make an informed decision to improve on what they eat. Then talking about the primordial level of prevention, policy, formulation, you know, engineering, construction. Most of these rural communities don't even have accessible road. So poverty is number one leading cause of all these problems that cause NCD. People eat anything they see, whatever they see. Some are not even eating well. And all this contributes to NCD burdens that we are talking about. So coming from this, it shows that there is a whole lot of challenges in funding, in changing people's lifestyle, in getting them informed about their health and their lifestyle. A whole lot of them don't even know that they need to control the amount of salt that they consume until this project came. So if you look closely, we are talking about rural community. What about urban? If we are able to replicate this also in the urban area, because no one is immune to NCDs. It affects both the poor and non-poor and the rich people, even the middle class. Everybody is at risk because there are so many risk factors that lead to this. Thank you very much. Let me stop here.
Yeah, thank you very much. I know you can go on and on, but there's a question from Reda Sadki, and I think it's similar to what you just mentioned. Maybe in 1 minute you can just respond to this. What is the current state of the primary healthcare facility, especially at the ward level, to actually support NCD patients, you know, especially around and their families with self-care and behavioral change? In brief, what do you think is the current state of our facility, especially at the ward level, to support NCDs?
Yes, at ward level, we have what we call basic healthcare provision fund facility at ward level. At least each ward has a facility that is equipped, well-funded, up to standard. This does not in any way, you know, dominating the bad ones. I'm not saying all the facilities are okay. At least there is one per ward that people can access within their political ward to actually access NPEN package. And healthcare workers in these facilities have been well trained over and over to attend to cases that are not complicated. And whenever they see a complicated cases, they also intervene and refer quickly to avert death. So I can assure the person asking the question that when you ask about your ward, ask about any facility that is under basic healthcare provision fund, you will be able to get access to NPEN package that we are talking about. Thank you.
Okay. Thank you very much. Thank you very much. And of course, we are getting there, or we get there. And then, interestingly, you talked about fund, but I'll move to Lucy to tell us what she thinks. There's a question by Johnson Okoye. He said, considering the cost of healthcare in Nigeria, is very high, how can these projects be more funded to reach more communities? So we talked about this. How can we get to reach more communities that cannot afford to access this kind of healthcare? Listen.
Okay, thank you very much, Moshood. So for that question, you know, when we're giving the background, the truth of the matter is that we know the cost of, first is the facilities that are even available, they are not accessible. And then the cost of medication is actually high, even when they are. So it was just last week, these health workers were coming to give medications to children for prevention of malaria. And I was asking them where they were coming from. The PHC, for instance, we have only one PHC that's covered. The PHC where they came from was very far from where we stay. And then people cannot go there to even access those services, whatever they have on ground. So now, talking about the funding, most of, like Dr. Kande said, we really need funding. The person that asked the question about the state of PHCs, still speaking to that, our PHCs are not very well equipped to even handle this basic primary care level, services. So we're looking out for opportunities where we can have funders, and then my joy is that NCD is also attracting attention at this moment, even in the World Health Summit last year. It's been about NCD. We're looking at opportunity where we can have more funding to be able to take these services down to the grassroots, down to the communities, to reach more facilities, to equip this facility. I remember our consultant in Kano, when she entered the Rich Clinic, she said, wow, that if all the PHCs in Nigeria are like this Rich Clinic, people will not be falling and dying anyhow. That was her comment exactly. Why? Because we don't have those facilities. The infrastructures are dilapidated. I know there are some, like she said, there are some that are well done, but a lot of them are not. So we're calling on the philanthropies, Nigerian government, everybody that's involved. Let us see how we can equip the PHCs, because they are very close to the people, the PHCs, and then build more and equip the ones we have and see how we can scale up that. So thank you very much. We should.
Okay, thank you very much. Samuel is asking if there are specific numbers or data on the prevalence of hypertension, diabetes among young people. I knew we provided some data at the beginning of this webinar. So of course, if you're registered to join this webinar, a recorded version will be sent to your mail, and that answers the question of Muslim Abubakar. Is asking if a recording will be shared. If you're registered to join this webinar, we have your email. We'll send this recording to your email. And then Nathaniel asks, how do we make this intervention very effective, considering the issues of regulating diets, seeing that most people, are poor? What he's trying to say is that, oh, you asked me to eat banana or fruits every day. I can barely afford to even eat a regular food, and you're telling me I should regulate my diet. I don't know. Yeah. I know time is fast running out, but can anyone just jump on this briefly? Oh, I'm poor, but you're telling me this is what I should eat. Can Dr. Nura, do you want to help out, or any other panelists?
Okay. Thank you, Moshood. Actually, the situation of the country, maybe people may be thinking how am I going to get a healthy food? Actually, with the little you have, there are very cheap, healthy food that you can afford, as far as you have money to eat a meal. You should use that money to eat a healthy food, not necessarily food. There are some substitutes. Even at our local diet, there are many local diets that are very healthy that we can use for our own consumption, rather than to eating let me use this fast food. Actually, if you can consider, the unhealthy food to some extent are more even expensive than the healthy ones. So I think you can do that. And before I go, I just want to highlight something concerning people are poor. I just saw a question pop up that people are poor, cannot afford medication. Actually, for BSc and Basic Healthcare Provision Fund, there is a provision for vulnerable population. Those that cannot afford, there's criteria for one to be vulnerable. Those ones that are vulnerable are being really enrolled in the BHCF Provision Fund for free, and they will be given medication. As currently in Kano now, apart from the even BSCF, we have Kano Health Trust Fund. There are some certain amount of percentage that being given to the health contributory scheme, whereby those vulnerables are being enrolled freely. I can tell you now we have more than 7,000 hypertensive vulnerable that are enrolled for the State Health Contributory Agency for free medication for hypertension. Thank you, and over.
Okay, thank you. Thank you very much. Again, if you have the right information, you get the right answers to majority of the questions you have if you get the right information. And then I think it's cheaper getting nutritious food than trying to treat yourself in hospital, spending time for tests, medications, and all that. So I think it's more affordable to get the right diet. We have barely 5 minutes to round up. I think we've to a large extent did justice to a series of our questions. But lastly, what are the few health tips you can give to our participants to prevent them from actually, to prevent them from contracting, say, hypertension, diabetes. Just one or two health tips, especially for young people. What are the health tips? Dr. Akonde, can you help us? A couple of health tips for, young people to prevent hypertension and diabetes.
Okay, thank you very much. Health tips is all about knowing your risk. Are you at risk of hypertension? There are certain risk factors you need to review. Do you have family history of hypertension? Is anyone in your lineage hypertensive? So if that is so, you are at risk. Even those without any member of the family with hypertension are also at risk. Apart from this, you will be able to now check on your lifestyles. So if you think you have strong risk factors to develop hypertension, so now what do? It's all about lifestyle modification. So the number one and the most important one is physical activity. Because even no matter what you eat, if you are not physically active, you cannot metabolize and live healthy. So if you are physically active, you take a walk like 30 minutes a day, like 3 times a week or on daily basis, it will go a long way. Just keep moving. Don't stay at a position for too long. Number 2, salt intake. You need to reduce your salt intake. A whole lot of our diet, our food are salt loaded. We will meet after cooking, we will still add extra salt into the food that we cook. We should stop adding salt to food. So how do you control your salt? When you cook rice, when you cook all those white food, stop adding extra salt to yam, to rice. Limit the one you put in the stew or the egg sauce or anyone, so that when you eat, you know you are actually controlling the amount of salt you take. Apart from salt intake, you also need to have a lot of rest. Nigeria now, we are, hustling for everything. We want to we want to look for money, extra source of income.
Yeah.
At the same time, you need to rest. Let's take some time to rest. So it will go way on your health. So I have to pause there because of time. Thank you.
Yeah, thank you very much. We are rounding up now. We'll be taking rest after this webinar. See, what does the future hold? What do you anticipate? What is your aspiration? In brief, in 1 minute, what is your aspiration on tackling non-communicable diseases? What's your aspiration? What do you look forward to in the nearest future? Again, in brief.
We're just looking forward. Okay. Sorry. So for me, I'm looking forward to when this becomes like a handled like HIV program where it's free, right? Because a lot of people are affected in this setting, and then they are handicapped to be able to access those treatments. I'm looking forward to when we have a lot of funding to be able to sustain that, and then building that also in terms of sustainability plan, how we can mirror that into the government, the national health system, national healthcare insurance scheme, or that we run across the federation. Thank you. Sorry, over.
All right. Thank you very much. Dr. Nura, your parting shots to Kano and Dabo and everyone, across Nigeria. Parting shots in 30 seconds.
Nice having you. And thank you, everyone.
Any message for people of Kano and the community?
Okay, well, it says the good message is that even the government is identify NCD as a priority as a part of the SWAP and sector-wide approach priorities across the country. NCD is one of the 13 topmost priority that the government is trying to see maybe in the next year that the government is going to address it, because we want to reduce the prevalence of NCDs in the country, which is not like that before. Therefore, I think we are, we are going to reach there by God's grace. Thank you.
Thank you very much. We are taking, we are taking intentional steps to actually tackle NCDs in our communities. I had an amazing time having conversations with you, and I'm sure our audience actually had a very good time. We were educated, we were informed, and I know at some point they were actually entertained. We really appreciate your time joining this webinar. If you enjoyed this webinar, please keep a date with us. next week. First, follow our social media platforms. For more engaging content on public health interventions. And if you enjoyed this webinar, keep a date with us next month. It's October, last Wednesday of every month is our webinar. Register and join our next conversation for another thought-provoking conversations like this. We really, really do appreciate your time. We appreciate our panelists. We appreciate all the participants that joined this webinar, both on Zoom and on LinkedIn. We do appreciate your time and have a wonderful evening. Bye-bye.
Thank you.
Thank
Health
you.
is wealth. Take care of yourself.
Thank you.
Prevention is better than cure. Bye.